Hi rabbits, Research Turtle here. Today we are diving deep into the evolving paradigm of acute coronary syndrome management. We often think of STEMI and NSTEMI as entirely different beasts in the acute setting, and they are, but there is a massive shift happening. While our acute strategies remain divergent, our long-term goal of preventing heart failure has converged around a unified standard of care, SGLT2 inhibition. Let's break down this journey from the acute divergence to the chronic convergence. First, we must understand why we treat them differently. It starts at the clot. In STEMI, we're typically dealing with plaque rupture. This exposes the lipid core, leading to a red thrombus, rich in fibrin and red blood cells. The result is total persistent occlusion and transmural ischemia. The full thickness of the heart wall is starving. In NSTEMI, the mechanism is often plaque erosion, leading to a white thrombus. The occlusion here is often subtotal or intermittent. Strategic divergence. This pathology dictates our strategy. For STEMI, the motto is time is muscle. We're racing against the clock. If you're PCI capable, the goal is wire crossing within 90 minutes. For NSTEMI, the motto shifts to risk stratification. It's not just about speed, it's about triage. We sort patients into very high, or low risk to decide when to go in, ranging from immediate invasive action to a selective stress test. Here's a critical clinical pearl regarding medication, specifically P2Y12 inhibitors. If it's a STEMI, we load immediately. We want that potent antiplatelet effect on board before we touch the vessel. But if it's an NSTEMI, the guidelines say do not pre-treat routine cases. Why? Because NSTEMI patients often have complex multi-vessel disease that might require CABG surgery. Loading them up front increases bleeding risk without proven ischemic benefit. So we've opened the vessel. The acute crisis is managed, but here's the unmet need. Even with successful PCI, the biological insult has already occurred. Now the patient faces a new threat, ventricular remodeling and heart failure. This is where we pivot from treating the vessel to cardioprotection, and the game changer here is the SGLT2 inhibitor. How does a diabetes drug save a heart attack patient? It's all about energy. An ischemic heart struggles to process fatty acids and glucose efficiently, leading to energy starvation. SGLT2 inhibitors trigger a metabolic switch. They promote the production of ketone bodies. Think of ketones as a super fuel. They provide more ATP per oxygen molecule than other fuels. This rescues the stunned myocardium, regardless of whether it was a STEMI or NSTEMI. The second mechanism is about unloading and protection. Hemodynamically, we get osmotic diuresis, reducing preload and afterload. But at the cellular level, SGLT2 inhibitors inhibit the NHE1 exchanger. This prevents sodium and calcium overload inside the cell. This is critical because it directly mitigates reperfusion injury and cell death. Does this theory hold up in trials? Let's look at MPACT-MI. In a population of high-risk AMI patients, empagliflozin reduced the risk of first heart failure hospitalization by 23%. Look at the forest plot. Was there a difference between STEMI and NSTEMI? No, the benefit was consistent across both phenotypes. We see similar signals in other trials. DAPA-MI showed a significant win ratio of 1.34, driven by cardiometabolic benefits like preventing new-onset diabetes. The EMI trial showed us that empagliflozin significantly reduces NT-proBNP and improves LVEF. Interestingly, there's a signal that NSTEMI patients, who often have higher comorbidities, might derive even greater acute protection against heart failure. This evidence has cemented SGLT2 inhibitors as the fourth pillar of heart failure care. The ESC 2023 guidelines now give a Class 1 Level A recommendation for ACS patients with LVEF less than 40%, regardless of diabetes status. It's no longer just a diabetes drug, it's a foundational heart failure therapy. So, how do we apply this tomorrow? Here's your checklist. Timing. Start it once the patient is hemodynamically stable, usually greater than 24 hours post-admission, and definitely before discharge. Safety. Ensure eGFR is acceptable, usually greater than 20 to 25. Rule out active UTI and rule out type 1 diabetes or DKA history. To wrap up, remember this image. In the crisis phase, we diverge. STEMI requires speed. NSTEMI requires stratification, but in the care phase, we converge. SGLT2 inhibition provides universal heart failure protection. We need to move beyond just treating the vessel. We must treat the risk. That's it for today. Turtle out.